Hello everyone, welcome to Aohua Vet's webinar. I'm the host from Aohua. First, let me introduce Aohua endoscopy. We was established in 1994, and we have focused on endoscopy system for 29 years, almost 30 years. At Aohua, and our goal is to increase accessibility and convenience when it comes to endoscopy diagnosis and treatment. And talk about our Aohua Vet webinar series. It aims to bring veterinary endoscope users together and to share their knowledges and experiences. It's a monthly event, so we want to provide a platform for an open discussion and the sharing of ideas, and also contribute to to the continued growth and development of veterinary endoscopy. Okay, so next, let me introduce our speaker today, Dr. Vasiliki. Her clinical interests including canine and feline gastroenterology, nutrition, and diagnostic interventional endoscopy in companion animals. She holds a GP cert in small animal internal medicine and GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate, and also a PG cert in small animal medicine from Harvard Adams University. Okay, so it's your time, Dr. Vasiliki. I will give you the host.
To share screen.
Yeah, and also please feel free to ask any questions in the chat box. Dr. Vasiliki will be very happy to receive all the feedback, and she will answer the questions.
I would love to make it interactive. Feel free to ask any questions, okay? Have you enabled me?
Yeah.
Share screen. That's great. First of all, I want to thank Aohua for this chance for continuing education, which is my passion, and to share, knowledge and ideas with all the colleagues all over the world. Thank you for attending, because I know it's, it's half hour, 1 o'clock, at least it's noon here in Greece. And we're going to talk about a very, very interesting and very common topic that we encounter in our everyday practice, which is the protein-losing enteropathies, their pathogenesis. I'm going to focus a lot in the diagnostics, and not only in the endoscopic diagnostics, but there are a lot of information, up-to-date information out there, and I want you to have it because this is the future of the veterinary medicine. And also, we're going to focus on the endoscopy, of course, in the endoscopic findings of the protein-losing enteropathies, and in the end, I will dedicate some time to speak about the novel treatments, because there are a lot of new treatments as well in this sector of protein-losing enteropathies, and because this is an umbrella term, as I will tell you. So there are a lot of new concepts about how to manage chronic enteropathies, both in cats and dogs. So let's start. It's going to be a long session today. Let's talk a bit about chronic enteropathies in dogs and cats. As you see here, this is a pie of the cases admitted to referral clinics at the Royal Veterinary College. And you will detect that 65%, I've shown this chart last time that we were talking about antibiotic responsive diarrheas and enteropathies. So you will see that this chart contains 65% of the cases that are admitted to referral clinics are food-responsive enteropathies. And these are the cases that you should not miss. These cases do not need and dedicated equipment or an equipment like an endoscopy equipment. They don't need any diagnostics, and these cases respond to food trials. And these are the cases that you should have in your practices and do not refer. Another 50% of cases are the antibiotic responsive diarrhea cases. These cases, with a highlight here of the German Shepherds group. And we have a median age, as you see, in the food responsive enteropathies of the 3 years old. These are younger animals in the food responsive enteropathies, and in the antibiotic responsive enteropathies, these are animals that are in the younger, are young adults, younger animals. So if an animal comes with diarrhea that's 1 year old, 9 months old, please do not use steroids unless you have excluded all the other extraintestinal diseases and you have made your food trials. And we will talk about the new concept on antibiotics. We used to use antibiotics as a second-line trial treatment, but now, due to the misuse and the overusage of antibiotics, we tend to actually minimize the use of antibiotics. And due to the dysbiosis that metronidazole, the wide use of metronidazole and the wide use of tyrosine and other antibiotics have caused to the intestinal microbiota. And then we have another 15% of cases that are steroid responsive enteropathy or immunosuppressive responsive enteropathies. And you see that the median age of these animals are 6 years. So they're older animals. And these are the animals that we will do the workup, the endoscopic workup, and all the other, and we will probably use the immunosuppressives and steroids. And then we have a 5% of cases that are non-responsive, neither to steroids, nor to food trials, nor to antibiotic responsive diarrheas, and they need different kinds of treatments, and I will elaborate later. So we used to have this pyramid here that we have the food responsive enteropathies, the biggest chunk, the biggest part of the animals that are submitted, then the antibiotic responsive enteropathies, then the immuno-responsive enteropathies, immunosuppression responsive enteropathies, and the non-responsive ones. But it seems that during this year, we have reversed a bit this pyramid. And of course, the food responsive enteropathies remain the biggest part of the cases admitted to our clinics, which means that whenever an animal is admitted to your clinic, you're not going to use as a first line prednisolone, prednisolone, or antibiotics. Try different diet trials, and we will see in the treatment section how we will do that and how patient we have to be, because I know that by the time chronic diarrhea cases reach to your practices, all the owners are so stressed and frustrated, and they have practically tried everything and nothing had worked. But you have to take it, you have to teach them, you have to be patient, and you have to teach them patience as well. So the food responsive enteropathies, and then we have the immunosuppressive enteropathies. This is the new data now. The antibiotic responsive enteropathies, we tend, as I told you before, not to use antibiotics as a first line. And it seems that they have been a bit overrated during the last years. And now with the common genes that we share, there's a huge danger for human public health, and we have to be very, very cautious, and we have to use antibiotics with caution. And of course, the non-responsive cases that are either with protein-losing enteropathy or not. So let's talk a bit about the pathogenetic mechanism of canine chronic enteropathy. And I like this term better than the idiopathic bowel disease. So when you hear the term canine chronic enteropathy, it's the old IBD But I never liked actually the term, because not all the cases are idiopathic. They could have some underlying component, which is not it has not an immunologic basis. So the canine chronic enteropathy has three pillars, the first of which is the environmental factors, the diet, the microbiota, and this is something that we can regulate actually. Of course, there is an immunologic component, and in some animals, there's also a genetic predisposition. And depending on how these three circles, these three different components interact, an animal can actually express the clinical symptoms or not. In humans, the line of treatments that we have is first the antibiotics and the ASA medications, then the corticosteroids. I'm talking about the inflammatory bowel disease, the Crohn's disease in humans, then the immunosuppressants like azathioprine, methotrexate, and cyclosporine, and biological therapy. In dogs and cats, it's totally different. So first of all, as a first-line treatment, we have our diet modification. Then we used to have the antibiotics, so we have to reduce and stop that. And as a third line, the immunosuppressants. The long-term prognosis of treatment in chronic enteropathies, as you will see, the food-responsive cases do pretty good with initiation of different diet trials. The ARD cases have the worst outcome and the worst prognosis, which means that once we take them off the antibiotic, they have a lot of relapses, and we have to reinstitute antibiotic treatment, or we have to try something else. And the steroid responsive enteropathies and diarrheas, 50% of those are responsive and 50% keep on having diarrhea. So you see that even in the steroid responsive group, in the immunosuppressant responsive group, whatever you do, only 15% of the cases will respond, and the rest we will say why they won't respond and what measures we can we have to in order for them to have a quality of life. And this is actually why we had to look out for different solutions. So what is a protein losing? What is the protein losing enteropathy term? This is not a disease. It is a clinical syndrome. It is an umbrella term which is used to characterize a syndrome that comprises of hypoalbuminemia and occasionally panhyperproteinemia. There is this misconception that in protein-losing enteropathies, we always have low albumins and low globulins. That's not always the case. We might have only low albumins, even in protein-losing enteropathies, as in the other two protein-losing situations, like the protein-losing nephropathy or the liver diseases that we mainly lose albumins. We have a deficit of albumins, but here we could also have only low albumins and not a combination. Chronic diarrhea, of course, ascites, because it is in the pathogenetic mechanism of hypoalbuminemia, and it's most of the times a low proteinic transitate. And we could have or not peripheral edema and a predisposition to an hypercoagulable state, a predisposition to thromboembolic disease. The breeds that are predisposed both to lymphangiectasia and in general to protein-losing enteropathies are the Yorkshire Terriers, the Rottweilers, the Basenji, the Shar-Peis, the soft-coated Wheaten Terrier, which in this breed we can normally see, apart from protein-losing enteropathy and protein-losing nephropathy as well, and the Norwegian Ludenhood. And there's also another classification of protein-losing enteropathies, which is according to the response they have to diet. So we have food-responsive protein-losing enteropathies and non-food responsive protein-losing enteropathies. So a lot of people ask me, is it possible to treat a protein-losing enteropathy when we have reached up to the point to have low albumin count and, all the side effects of that? Is it possible to treat it only with dietary trials and maybe peripheral support with other agents that we will talk about? Yes, it is absolutely possible. It is absolutely possible not to use steroids as a first-line treatment once you have the histopathologic examination test result, as it is absolutely possible to treat inflammatory bowel disease without using the steroids as a first line. And I'm only talking as a first line. Okay, and the causes of protein-losing enteropathy: lymphatic vascular obstruction, increased mucosal permeability due to severe mucosal infiltrates, and which are the diseases that actually fall into this category? All the infiltrative diseases, eosinophilic, lymphoplasmacytic, steroid-responsive enteropathy or immunosuppressive responsive enteropathy, systemic mycosis, histoplasmosis for the areas, the geographical areas that can actually have histoplasma and pythium, primary intestinal lymphangioplasia, and beware, because primary intestinal lymphangioplasia most of the times does not implicate an inflammatory component. Of course, we could have inflammation due to the lymphangitis, but most of the times we do not have an inflammatory component. Alimentary lymphoma, and of course, creep disease. Also, mechanical causes can cause protein-losing enteropathy, ulcerative GI disease. A lot of people ask me sometimes, when I have an IBD, will it definitely process into protein-losing enteropathy? Most of the cases, it will not. But once I have an ulcer in this IBD, once I start have ulcerations, then this is a trigger to progress to ulcerative, for my IBD to progress into protein-losing enteropathy. Chronic intussusception as well. And there's another category of protein-losing enteropathies. Apart from these two basic mechanisms, the focal the FLL, lipogranulomatous lymphangitis. These are Greek words and I cannot pronounce them. So in these cases, we have increased wall thickness of the ileum, of the jejunum, or of both parts of the small intestine. And we have mass-like lesions on the serosa that can also extend to mesentery. And sometimes when you have full thickness biopsies, you can detect them. So let's go to the cases. And if you have a question, if you want to discuss one of your cases during these sessions, you're most welcome to do so. So we have a German Shepherd, and beware of the age. Young German Shepherds, antibiotic responsive diarrhea, or small intestinal bacterial overgrowth or intestinal dysbiosis. Older German Shepherds, IBD or steroid responsive enteropathies. Okay, so you have sometimes the age plays a great role into differentiating in which direction we will, which path we will take, either diagnostic or as a treatment, for the treatment. So we have a German Shepherd, 7 years old, female spayed, and the body weight is 27, fully vaccinated and dewormed, lives indoors. She's not an outdoors dog, and no other cats or dogs in the family. So it's a single, it's the only dog in the family household. So she came with a chronic intermittent diarrhea over the past 2 years. This dog has been having a gastrointestinal problem during the past 2 years, and it's not that she wasn't under different treatments, but none of them resolved the problem. So we had increased, what are the characteristics of the diarrhea? Increased fecal volume, watery, okay, and absence of mucus or blood, normal defecation frequency, and increased fecal volume depicts problems of the small intestine, okay. Intermittent vomiting, selective anorexia and depression, pica. She was outside. When she was outside, she used to swallow grass, foreign objects. She used to lick a lot of all the surfaces of the house. And this depicts abdominal, this suggests abdominal discomfort. Okay, and dyspnea, and it's only obvious why this dog has dyspnea. This dog has a huge ascites, as you see, and sometimes the owners, for example, said that they haven't realized that their dog had lost so much weight because the abdomen was so distended that they didn't perceive it as a weight loss. So you really have to be careful about the weight loss perception of owners, because sometimes of the pet parents, because sometimes ascites might actually hide the actual weight loss, but it's only shown in this animal. So let's watch a bit the physical examination. You see the ribs and you see the muscle atrophy that this dog has. Okay, so we have an abnormal abdominal contour. The detection of the fluidways in the percussion, in the palpation, please always do a good abdominal palpation. We might do, you think that these examinations are very silly or very, basic, but they can give you so many information for your patient. And it's always great, to know what you palpate, the liver, when you palpate the liver, the margins of the liver, the margins of the spleen, where every organ is located. Maybe we'll do a video on that as well. The body condition score, very low, despite the look that the animal has, that it looks very chumpy. The respiratory rate is increased because it has such a huge peritoneal abdominal effusion that it causes diaphragmatic compression, and this causes the dyspnea as well. The mucous membrane is normal, the temperature normal. Also, there was a secondary pyoderma in impetigo, and we always have to ask if the animal is pruritic, if the animal is itching, and this animal was itching, but we first have to treat the secondary infection of which is the staphylococcus, in order to see if there's any underlying allergies to any, if this dog is atopic, for example, or if there is a food allergy component there. The fecal score was 7, and I would urge you to do these 2 last examinations, the CBDI and the CCI score, and the fecal score. Use these charts because these are the most important examinations and numbers that you have to have in a GI examination, in a gastrointestinal examinations. This could save you time. This could save, even the endoscopy procedure sometimes can be saved. I know that I'm not supposed to say that, but it's the truth. Because they have a high predictive value, these 2 last scores, the CBDI and the CCI score. So in this animal, it's 14, and we will see what this means. Use a fecal scoring system. Why use a fecal scoring system? Because sometimes the owners tell you, it's a bit mushy, it's a bit watery, but if you show them what exactly the chart is, then you can have a very objective image of what actually depicts the animal's feces if you haven't seen them. So let's be objective and not subjective, and always use the chart in front of the owners in order to have a common, communication code. So this is what 7, watery, not texture. And this is in our hospitalization area. These were the feces of this German Shepherd dog. And these are the 2 scores. And why should we use them? It's easy, it's practical. They all can come down to a single number, both of them. And I tend to use the CCI score better. So they all come down to a number, and this number really gives you, as you see, that most clinical studies do not show any difference between endoscopic scoring and clinical indexes. Of course, this is a bit debatable because maybe we do not take so good endoscopic samples in order to match the clinical indexes. Maybe this is a problem of the histopathology interpretation, but most of the studies up to now do not show any difference between endoscopic scoring and these indexes. So if you have a high clinical index score, this means that you have a severe disease. So cutoff value for CCI score is the 12. So if you have above 12, then this is significantly associated with a poor prognosis and a poor therapeutic response. And you should say the owner even before doing your endoscopy. And these dogs should be treated earlier. These are the dogs that we will not do 3-foot trials, for example, but we will start treating more aggressively because they have a high clinical index. So you understand, I really want to highlight how important it is to just adapt this number. It will give you great information, great input, objective input that you then can communicate to the owner. And you will not have an owner complaining, oh, why this dog is not doing well. We have given high doses of prednisolone or prezolone or whatever, and it doesn't respond because first, as I told you earlier, that only 15% of the cases, half of the cases, will respond to steroid treatment. Whatever you do, however well you maintain your case. And secondly, if you have a high clinical activity index score, then there's nothing else to say to persuade your pet parent, and actually to persuade yourself that you're doing your best. Okay. Let's see the hematology and biochemistry profile of this dog. The HCT was normal. Okay, thrombocytosis. This is very, very common in these patients. And why do we have thrombocytosis? Because we have loss of antithrombin 3. As we said, these patients are in an hypercoagulable state. Okay, we have a low BUN. Why do we have a low BUN? Because this dog is not eating very well. The creatinine levels, though, were low and normal. And why the creatinine levels were low? Because they're not shown here, but they are low because we have a muscle atrophy. The muscles are so thin in this animal. Okay, and creatinine levels are actually influenced by that. And we have a very, very low total proteins count. So we have both albumins and globulins low, and a cutoff value of albumins lower than 2 in IBD cases are associated with they're a very bad prognostic factor. They're associated also with bad outcomes. Okay, we have a low total calcium. Is that true or not? Whenever we have hypoalbuminemia, we always have to correct the total calcium. But if your ionized calcium is low, then things change. And if you have, for example, an animal that is presented with facial rubbing, and I forgot to tell you that after I saw the ionized calcium, I asked the owners, does the dog rub its face, or does it rub it to, sofas or to surfaces? And it did. And this is muscle tremors, facial rubbing, focal, or of course, generalized seizures are very, very indicative that we have a low iodinized calcium. And when we have a low total calcium with an hypoalbuminemic patient, we don't worry that much. But when we have a low iodinized calcium, then we definitely have to take serious consideration to correct it, because this means that it's probably associated with low serum 25 hydroxy vitamin D, and also with concurrent hypomagnesemia and secondary parathyroid gland disorders. So we definitely have to take a good look on on the interpretation of our biochemicals. And we have, do you run a baseline cortisol throughout typical Addisons? Thank you, Jacqueline. Definitely, we will say now we're on the first stage that we have our biochemicals. We definitely do that always to all our GI cases. And for an additional reason in this case, Jacqueline, can you figure it out? Because we have a low cholesterol. And low cholesterol, even if I have normal electrolytes, as you see, I don't have hyperkalemia. Even if I have normal electrolytes, the Addison's is the only endocrinopathy that can give low cholesterol. Okay, low cholesterol is indicative of a problem of either Addison's or a problem in the small intestine. Okay, because it's correlated to, it's associated to malabsorption and syndromes. So we have a very low cholesterol, and thank you for pointing it out with your question. And you always have to measure. There is no gastrointestinal case that you will not measure albumins, globulins, and cholesterol. Please, those three should always be measured. And of course, if you have the luxury, measure ionized calcium, magnesium, that I didn't in this case, electrolytes and everything. And before doing anything else, before proceeding to imaging or anything else, you will do your fecal parasitology. And I always repeat it 2 to 3 times in order to make sure. And we try to detect, Giardia cases. Please beware that Giardia is in the small intestine. A lot of people get it mixed, They are confused, and it's not a good way to detect Giardia in endoscopic samples. So please have your parasitology examination done, at least one, zinc sulfate, Barman, direct fecal smears, cryptosporidium, check for crypto and everything. Do not do a fecal culture, because most of the pathogens like salmonella or even Clostridium can be in the healthy population, population of dogs with a normal feces. So don't bother about a culture. I will tell you all of our alternatives, especially in the Yorkies, but in every animal. Extremely low calcium levels, as I told you, can also lead to serum, to concurrent ionized hypomagnesemia, and also secondary parathyroid gland disorders. And always correct your total calcium with this type, because most of the times it could be normal and it doesn't need correction with intravenous fluids. I want to, for 1 second, highlight the role of vitamin D in chronic enteropathy cases. So low vitamin D is correlated, gives a negative prognosis also to the cases. There's no consensus into supplementing vitamin D for now, but we can do other things that we will talk in the treatment section. We can give calcitriol, for example, in these patients, and this changes everything. So what do? We investigate the hyperproteinemia, and we exclude whenever a GI case is admitted to our clinics, there are two main pillars: the extraintestinal diseases and the primarily intestinal diseases. So we exclude all the intraintestinal diseases, and then we do our workup in the intestinal diseases. But first, the lead that we have here is to investigate why this dog is hyperproteinemic. Okay, and in general, we have these three categories. I'm not going to go into the pathophysiology of hyperproteinemia. We have loss of albumins, actually not loss. We don't have production of albumins in liver disease, because this is the place where albumins are synthesized. Okay, so in liver diseases, we have low albumins counts. In kidney diseases and in protein-losing nephropathy, we have low albumins as well. And in intestinal diseases, we used to say that we had both low albumins and low globulins, but this doesn't count for all the cases. For example, in the Basenji enteropathy, we could have normal globulins as well, and not only the Basenji enteropathy, and also in histoplasmosis, we could have, or in other infectious diseases, we could have high globulins sometimes. Okay, so don't get it confuse you if you don't have both albumins and globulins to say that to exclude protein-losing enteropathy, because this is not the case. So we did a dynamic bile acid tests, even if the if you saw priorly in the biochemicals of this dog, all the transaminase, all the liver enzymes were normal, yet we did a dynamic bile acid test in order to be certain pre and post were normal, okay? In order to exclude the kidney disease, we did a urinalysis, and the specific gravity was normal. And this is another thing that excludes also Addison, because most of the Addisonians that have electrolyte disturbances due to hyponatremia, due to low sodium, they have a diluted urine, like in the renal patients. So the sediment was inactive, so we exclude protein-losing nephropathy as well. And of course, we definitely, in these cases, we have a malabsorption case here. We have a chronic diarrhea case. It's a German Shepherd, you know, and even if it weren't a German Shepherd, we always have to exclude the exocrine pancreatic insufficiency. And we did it CTLI. Beware, your CTLI should be done under 12 hours of fasting, okay, always. Otherwise, you will not have good results, valid results. And also, if you have your CTLI can actually be influenced by high creatinine and BUN levels, so beware of that. If you have a renal patient that you want to check the CTLI, maybe you should look, you know, for an alternative examination. And in our CTLI, it was normal. It was unremarkable. Cobalamin, always measure B12, because most of these patients are deficient, especially cats, but also dogs. Okay, and a low cobalamin cutoff value of 272 is highly, again, associated with very bad prognosis. And here we had an increased folate as well. So we used to say that small intestinal bacterial overgrowth, we say now dysbiosis, intestinal dysbiosis. So high folate and low cobalamin is suggestive of intestinal dysbiosis, not intestinal bacterial overgrowth. This is a very poorly marker for antibiotic responsive diarrheas. If you have low folate, in some cases we do not have increased folate, we have low folate, and that reflects disease in the jejunum. Okay, so you see that with some biomarkers, which are very, very important in chronic small intestinal diseases, you can actually have a primary location of your problem, okay? And the low cobalamin reflects also distal small animal disease, ileum mostly. but also a diffuse a small intestinal disease. And you could have some artifacts of a low cobalamin, which are mentioned here. So our next step, we have a dog with ascites. Okay, what do we do? Of course, we have an abdominal paracentesis to see what kind of an effusion we have. So the color of this effusion was clear watery, low specific gravity, total solids low, the nucleated cell counts low. And in these nucleated cell counts, we had a mixed population of macrophages, lymphocyte, and mesothelial cells. And I'm not going to elaborate on this slide, but we had, in our case, of course, as you may imagine, a pure transudate due to the hypoalbuminemia, due to the low oncotic pressure. And also, just a reminder of the other two categories, the modified transudate and the exudate. Okay, there has to be a classification of some kind because it will help you in your diagnosis. And this is my favorite part now, because these were all the markers that we had up until now. So in order to diagnose the canine chronic enteropathy, you see that we have an inner circle of the most common tests that we perform as clinicians in our everyday clinic, like the patient's history, the physical examination. The patient's history for me is a huge part of your diagnosis in these cases, because most of the cases are lost when we fail to locate the problem. Okay, physical examination, the routine clinical tests that we do, diagnostic imaging, of course, and treatment trials, and there's special diagnostic tests that we did in order to exclude all the extraintestinal diseases, but there are a lot of other markers out there. And the future of gastrointestinal medicine in a few years will be totally different than we know it now. Which are these markers? These markers, the C-reactive protein, for example, these are biochemical or functional biomarkers, or microbiolomic or metabolomic, that some of them we can use in the everyday practice and others we cannot. For example, I have a question for you here. Which of the following tests could be used to determine whether a dog may benefit from cobalamin supplementations? Because we have a lot of supplementation, because we have a lot of animals that are admitted with normal low B12, normal low, around 280, 300, with a cutoff value of 250. And we say, oh, it's normal, I will not supplement. But these animals actually are in huge need of supplementation. In humans, does anyone know? If you know, just put it in the chat box. In humans, we have the luxury of measuring the serum methylmalonic acid, which actually indicates if the B12 that circulates is biodisposable, is bioavailable or not. In dogs, unfortunately, we don't have this luxury yet, but this is the marker, the serum methylmalonic acid. But if you don't know and if you can measure the serum MMA, and some companies I know that now measure MMAs for dogs, if you can't have the luxury of measuring MMAs, please go ahead and in every patient that you see with a low normal, even if the B12 is low normal, do injections or give, and these animals, of course, suffer from chronic enteropathy, supplement them with B12. It's non-toxic, they're water soluble, so there's no toxicity, there's no, accumulative toxicity in these vitamins. So please do, and your animals will your patients will feel better. The fecal A1 proteinase inhibitor is actually to detect protein-losing enteropathies, to diagnose protein-losing enteropathies. The serum C-reactive proteins are, it's not a specific for, it's not a marker specific for IBD, but we should measure it because it's an inflammatory marker. And the same is with fecal calprotectin. And in humans, they're very, very, they use these markers in order to make our lives easier. Okay, and as you see, there are a lot of other genomic markers out there. The one that you can actually use is the canine and feline microbiota dysbiosis index. It's not broadly available, but the Texas University measures these 7. I'm going to show you what this is. So it's a quantitative PCR test. This is so helpful. And this is the future of gastroenterology, actually, because it shows the dysbiosis index as the other index that I have shown you previously is a quantitative PCR test, and it targets 7 important bacterial taxa. And based on the abundance of one of Clostridium chirononis, we can predict actually a decreased abundance of Clostridium chirononis actually predicts the decreased conversion of primary to secondary bile acids. Secondary bile acids are very, very important. And you're going to say, why are you telling us all these boring things? Because with only this marker, and with only knowing that if you give metronidazole for 10 days, you're going to have a reduction of Clostridium chirononis for 4 months, for up to 4 months, you will be very, very cautious into prescribing and into administering metronidazole the next time you want to, because you alter the microbiota in such a way that's irreversible for many, many months. So if we have low Clostridium chirononis, then whatever you do, you will never fix the diarrhea problem. This is why you have to know this. So secondary bile acids have both local and systemic anti-inflammatory properties, and they play a crucial role in suppression of dangerous bacteria like Clostridium difficile or Clostridium perfringens or E. coli. So if you have low counts of Clostridium difficile, of Clostridium chirononis, then you're going to have an exacerbation of the bad guys in the intestine, which are the Clostridium difficile and perfringens and the E. coli, because you don't have secondary bile acids, and a lot of primary bile acids are in the colon. Okay. And this leads to intestinal dysbiosis. And whatever you do, whatever antibiotics you use, whatever corticosteroid you use, you're not going to fix that. You'll never fix that. So if the dysbiosis index is more than 2 in dogs and more than 1 in cats, that's a major shift in dysbiosis. And if your dysbiosis index is between 0 and 2, then that's a moderate shift. And this is why a lot of you that refer cases, you say that we have done everything. We've given antibiotics, we've given metronidazole, we've given tyrosine, we've given, enrofloxacin, and nothing seems to work because you have destroyed the intestinal microbiota and you have destroyed the populations of Clostridium chirononis. This is why. Okay, and you have to reinstitute that before going into other treatments. And of course, welcome to the future. This is a test that I've heard from Karen Allensbach. They're trying to, what gastroenterologists are trying to do is find markers that will not lead to endoscopy. And I know that I shouldn't have said that again, because we're in an endoscopic lecture and endoscopy is my, is my passion. But what gastroenterology is all about now, they're trying to find biomarkers that will actually detect the diseases and that will discriminate between diarrheas that come from chronic enteropathies and diarrheas that are attributed to other diseases, so that only the cases that actually need it will be leaded to biopsies, because you ultimately you will have to have biopsies. But as you see, there is this examination, the SPARKLE examination, And it can, it detects fecal gastropropin concentration. And this was the only biomarker. There were a lot of biomarkers tested, but fecal gastropropin was the only biomarker that could discriminate between chronic enteropathy and chronic and other and diarrheas that are non-chronic, that are not attributed to chronic enteropathy. And also for steroid responsive diarrheas, we had higher, as I told you, CCI scores and weight loss, and higher concentrations of gastropropin as well. So you see that these two indexes, the dysbiosis index, the CCI index, and these new examinations can give you a very good overall idea of whether the problem is located in the gastrointestinal tract or not. Okay, so welcome to the future. Let's go back to our case. Of course, we did an abdominal ultrasound. We had a thickening of the intestinal wall. The pancreas was normal. We also had mesenteric lymphadenopathy. If you have enlarged mesenteric lymph nodes, just, do an FNA. You might exclude lymphoma in a lot of cases in a very easy way. And of course, free peritoneal fluid. Focus more on echogenicity and the derangement of the wall layer rather than the actual thickening, okay, because we have a lot of IBD cases that are not lymphoma, and we have the muscularis, for example, thickened, and they're not lymphoma cases. So we have to have the layering, the structure of the intestine, the derangement of the wall layering in a proper way. And if we detect anything abnormal there, then this is a problem. This is a point to be worried about. And of course, we did an endoscopy, gastroduodenoscopy. In the stomach macroscopically, we had, some erosions, as you will see, in small ulcers, ulcers, pinpoint ulcers in the antrum, in the antral region. But nothing remarkable, maybe a mild diffuse gastritis. And in the small intestine, we had increased granularity and increased friability. Okay. And let's see the endoscopy of this dog that had very, very low albumin count. Okay. So this is the esophagus. As you see, it's a flaccid esophagus. It has some foam material. And the sphincter is open. The cardiac sphincter is open, maybe due to anesthesia. And I stayed there for a while to see if we have any gastroesophageal reflex, because if it was open during the time that the dog was alert, we should have some gastroesophageal reflex disease, which we didn't. The part that you saw in the esophagus was the Z line, okay? Don't misinterpret the Z line with esophagitis. And here we are in the stomach, and you see that this dog actually consumes a lot of grass, and this dog was fasted for more than 12 hours, 16 hours, and still has fresh grass in the stomach. Now we're heading to the pylorus, okay, because all the rugae lead to the pyloric region. And you see some when we reach to the pyloric region, you will see some small dots here, for example, an ulcer, a small ulcer. But in general, the mucosa of the stomach is, not inflamed. And this is the J maneuver. We saw, we retrograded the scope. And here you can see some small ulcerated regions as well. This is the pylorus, lots of grass, and the pyloric region. So you see these small ulcerated areas. And let's go to the small intestine. So you'll see that the mucosa has edema, and you see that we have lacteals, like the like in lymphangectasia, because a lot of cases of protein-losing enteropathy, even if they're not primary lymphangectasia, due to the progressed IBD, we tend to have secondary lymphangectasia in these cases. So we have full lacteals, and they're prominent, and we also have an increased granularity and friability. And I love the intestine. It looks like a coral, you know, in the coral reef. And we have edema, and I tend always to take biopsies, you know, not blindly, but keep the biopsy forceps real close to me so that I can have a bigger chunk. And if I don't like it, I try again, as I did here. We have normal peristalsis. We have peristaltic waves, as you see, in the intestine. And you will see that I'm trying to get a second biopsy because I didn't like my first grip. Granularity, yes, Jacqueline. Granularity is when the small intestine should be smooth, you know, like velvet. When you have lumps and bumps, as the dermatologists say, in the skin, and I will show you some other cases later that you will understand it even better. This is when you have granularity, when it's not smooth and it has, you know, protrusions in the mucosa. Okay. Yes, I have a very clean intestine, but this is small intestine, Anna. It's not large intestine, okay? So I will have for colonoscopy, I will definitely give you a protocol if you want. But this was small intestine, and if you fast your animal for 16 hours, it should be like that. You shouldn't have, you know, fecal material. You don't have fecal material in the small intestine. Okay, and in the histopathology result, gastric biopsies, even though we had these small ulcerations, you know, these small lesions, and we took biopsies from these exact lesions, they were normal, which means that we didn't have any infiltrates, severe infiltrates in of lymphoplasmacytic, you know, gastritis. Could it be, you know, I normally take 10 to 12 biopsies from the stomach, and it could have been the case that I was, you know, that maybe we had lymphoplasmacytic gastritis in other parts of the stomach, which I doubt, but, you know, everything is possible. But anyway, it came out with mild lymphoplasmacytic enteritis, gastritis, and it was not, you know, depicting the actual clinical presentation of the animal. When you have an animal with hypoalbuminemia and emaciated and with ascites, I mean, you expect to have gross lesions in your histopathology result, you know. And the small intestinal biopsies, though, were very rewarding in terms of being diagnostic. We had severe infiltration of the villus and the pericryptal lamina propria with mixed population of lymphocytes and plasma cells, and we have some eosinophilic clusters as well. So we had a mixed inflammatory bowel disease, mixed chronic enteropathy. So the diagnosis, protein-losing enteropathy as a result of severe IBD, and secondary small intestinal dysbiosis, okay, for this animal. Let's go to a second one. I don't know how much time we have left, but let's go to a second one. Okay, this poor dog, it's a Dashwood female, 4 years old, and you see that it's practically emaciated. What is the clinical history? Chronic recurrent episodes. You see that this dog has ptyalism. It has nausea in the examination, in the consultation room, okay? And it's drooling, hypersalivation, okay, in a very, very bad nutritional state, practically emaciated. Okay, the history, clinical history, large volume diarrhea, but we also have increased frequency of defecation. So this is a mixed pattern. This is both from the small intestine and large intestine. Okay, intermittent vomiting, and we have appetite alterations. There are periods of time that this dog is polyphagic. We have other periods of times that it's hyperexia or totally anorexic. And of course, this dog is scavenging, is salivating all the surfaces, you know, licking all the surfaces. It has abdominal discomfort. Borborygmy, okay, hypersalivation, as we said. And it was administered for bendazole, metronidazole, tylazine, the whole spectrum of antibiotics. Amoxicillin and clavulanic acid, I do not know why. A hypoallergenic diet was tried with hydrolyzed protein for 4 weeks, and human probiotics were used, and 2 cobalamin injections, thankfully, but no response, no clinical response. Okay. Physical examination findings, always do the body condition score, the muscle condition score, the fecal score, and why did I miss the fecal score? The CBDI score, here it's 14 for this animal. Anyway, palpation of the animal, mild thickening of the intestinal loops, body condition score 1 out of 9, muscle condition score D. This is an emaciated stunned dog. Okay, respiratory rate and the BPM normal, the fecal score 7, and the CCI score and the CBDI score were 12. No, sorry, it was 14 in the latter one, and this was 12, okay? These are the feces of this dog, okay? They're watery, but this is not, they're large, they're of large volume, but this is one of the pictures that the owner has sent me, but it's much, much more than that, okay? Our problem list: mixed origin diarrhea, weight loss, polyphagia, pica, and coprophagia as well. So we have to have, as I told you last time, a differentiation between maldigestion and malabsorption. Maldigestion is the impaired breakdown of nutrients, okay? And the malabsorption is the defective mucosal uptake and the transport of adequately digested nutrients. So we have already in malabsorption, we have already digested the nutrients. These are the mechanisms of malabsorption, and as you will see, lymphangectasia is one of them. And of course, all the enteropathies and the small intestinal dysbiosis. So what do we do when a patient like that is admitted to our clinic? What do we do? Patient's history, physical examination, and you see that we always have to just add up the number. It's just a number, the CCI score, okay? Blood testing, urinalysis, and fecal parasitology. The gastrointestinal panel, what is the gastrointestinal panel? As we said, cobalamin, folate, CTLI, and maybe CPLI in some cases, or DHGR lipase in order to exclude pancreatitis, and a baseline cortisol, as Jacqueline has very well pointed out. Diagnostic imaging, abdominal ultrasound, and thoracic radiographs, especially in PLE, in protein-losing enteropathy cases, in order to see if we have an accumulation of fluids. Okay. So what do we do? In a stable patient, we do a dietary trial with an ultra low-fat diet, okay? And if we have response, then we have a food-responsive protein-losing enteropathy. If we don't have an acceptable response, then we have to try a different low-fat diet, maybe a novel protein low-fat diet, okay? Restricted antigen is the novel protein or anhydrolyzed. And then in an unstable patient, of course, we have to give supportive care, if needed, tube feeding, and then do further diagnostics like endoscopy or, full thickness biopsies. And what you do with the patients that have so low albumin count and you have to have full thickness biopsies, then you support them. You infuse albumins and then you do your biopsies and then you re-measure your albumin counts, and then you might also give again, administer, re-administer. Okay, let's see what was going on with the rest of the panel for this poor dog. Fecal examination parasitology, negative. Barium, zinc sulfate, as I told you, Giardia, Cryptosporidium, everything negative. The CBC revealed a mild non-regenerative anemia, maybe to chronic, disease. A lymphopenia and a thrombocytosis, again, as I told you, due to loss of antithrombin 3, and not only. Hypercholesterolemia, hypoalbuminemia, but the globulins were normal. They were low normal, but they were normal. This doesn't exclude protein-losing enteropathies, okay? Hypokalemia, because they lose potassium through the diarrheas, and hypocalcemia, but it was total calcium low. So we have to first, as I told you earlier, correct the calcium or measure ionized calcium as well to see what's going on. The baseline cortisol was normal in order to ultra low fat diet there are commercial diets like the ID low fat or the gastrointestinal low fat of Royal and of Purina as well, that are ultra low fat diets. Or you can have ultra low fat diets. There are diets that have less than 20%. I will show you later in the treatment, Patrick, less than 20% of calories, okay, from fat. I will show you later as well. And also you can build up with a clinical nutritionist. Okay, and the baseline cortisol normal. For example, because I have to answer this as well, when you have a novel protein diet, could be a low fat, but ultra low fat are the commercial diets that have 7%, 8% of fat. I will show you in the treatment your choices. Okay, again, investigation of hypoalbuminemia. Gastrointestinal panel, okay, TLI normal, pancreatic lipase normal, cobalamin normal. You see that it's normal, and it's not low-end normal, it's normal. And folate normal. So we excluded the exocrine pancreatic insufficiency. Liver disease. Now we have to exclude all the extraintestinal disease as we did in the previous animal. Liver disease, dynamic bile acids test, normal. Urinalysis, normal. Inactive sentiment, so we don't have a protein-losing nephropathy. Abdominal ultrasound, mild mucosal thickening of the duodenum without any loss of the normal ecotexture. Okay, abdominal lymph nodes normal. Can I have IBD or protein-losing enteropathy and have a normal ultrasound? Yes, I can. A lot of the times you will not see this striation in protein-losing enteropathy cases, unless they're very, very progressed. Abdominal lymph nodes, normal. And the gallbladder had a bit of abundant mucoid content here. Okay, let's watch the endoscopy. You see these white spots. These white spots are highly suggestive of hypoalbuminemia, okay? We have increased friability because it's not smooth, it's not, without any lumps and bumps, moderate edema, normal peristaltic waves, and of course we have dilated lacteals. There was something that I wanted to tell you. As you're watching the video. So you see all these white spots. These are highly indicative of lymphangioplasia. Full thickness or endoscopic biopsy, which is more diagnostic. It depends on what you want to diagnose. For example, for IBD cases or for lymphangioplasia cases, of course, you can do an endoscopic procedure, but you might miss. I know that I understand that you're talking about lymphoma cases or low-grade lymphoma cases, especially in cats that resemble highly to IBD. If you're a very experienced endoscopist and you can get 2 biopsies or bigger chunk of biopsies with specific biopsy forceps that take 2 times at the same spot, then you might as well have a lymphoma diagnosis. You might achieve a lymphoma diagnosis. Is it dangerous to do it in the full thickness biopsies in low albumin patients, in hypoalbuminemic patients? Yes, it is, but you have to infuse albumins, human recombinant albumins, before and after in order to maintain a good albuminic level. It's safer, of course, to go less invasively and see what you achieve. Okay. Is the level of albumin that you would not even do endoscopy? No. I would do endoscopy with 1.6, with 1.8. Albumins is fine. And 2 or above 2 is much safe, is very safe also for full thickness biopsies as well. Okay, so don't be afraid of that, of dehiscence. I know that you are, but you have to monitor and then administer as well, even post-operatively. Okay, let's see. And the histopathology results, primary intestinal. This is primary intestinal lymphangioplasia because we have very, and galt hyperplasia. We don't have much of inflammation here. So we have very mild lymphoplasmacytic infiltration. And as you see in the histopathology results, we have some crypt ectasia as well. We have crypt dilation of the intestine. Very few superficial lymphocytes and plasma cells. So this is not IBD. This is intestinal lymphangioplasia. And I do not know why people think that this is the same thing and they treat it as if it were IBD. And I was talking to one of my colleagues yesterday about that as well. So lymphangioplasia could be primary lower due to congenital disruption or idiopathic. In this case, it's idiopathic, okay? Or secondary due to lymphoma, alimentary lymphoma, or due to IBD. Or we should always check the heart of these patients due to venous hypertension, congestive heart failure. And we have also to exclude all of these diseases, Yorkshires, Rottweiler, soft-coated Witten Terriers, these breeds are highly predisposed. And Jacqueline, here you will see better what I mean when I talk about granularity. You see how this is dotted. So we have multiple white spots indicating dilated lacteals. Beware that if you do an endoscopy in a fairly normal animal after a meal, could have this appearance, not exactly this, but the lacteals could be dilated as well. So my question to you now is, how can I differentiate between this situation you see the diagnosis. I should have hidden the diagnosis. This situation here, this is too bumpy and lumpy. This is with highly increased granularity, okay? This situation here, macroscopically, I say, okay, you see this is a mess. This is a very, very highly edematous and with a lot of dilated lacteals. erosions. This is not from my scope. It would be more from your scope. You will always have more linear lesions. This one, which is severe IBD, and this one, which is lymphoma. You cannot differentiate without biopsies and without proper biopsies. Sometimes it's even difficult with endoscopic biopsies to differentiate between amongst these diseases. Okay, so you always have to end up to endoscopy, and with the help of all the other markers that we said. Let's go back a bit to this one. So there is this entity as well that we have. We can have in IBD these spots. It could be singular, it could be multiple, and these are due to low serum protein and low albumin concentration. Okay, they're very, very easily detectable. And I will spend 5 minutes on we're 16 minutes past our hour, but I will spend 5 minutes. It was a huge subject. I will spend 5 to 10 minutes on the treatment. So when we have a severely affected patient, we go into rescue treatment. And there are 3 pillars that we have to restore. Increase the oncotic pressure, either with plasma, synthetic colloids. I know that a lot of people are really, really afraid of the human recombinant albumins protocols due to allergic shock, due to allergic, instances right after the infusion. If you do it with the right protocol that I can share with you, whoever wants can email me and I will send you off the protocol. It's very safe. We do it, in our everyday practice. And this is how we can take also full thickness biopsies from severely hypovolemic patients. Management of ascites, of course, with diuretics. Please beware of furosemide because you can, these patients have already suffered hypokalemia due to the chronic diarrhea, and you're going to make it more severe. You're going to make them more severely hypokalemic with furosemide. Also, if you reach up to a point that your ascites is not listening, is not responding to these dosages, 2 to 4 milligrams per kilo, then you should turn to another diuretic. Don't increase the dosage. Or you could also, sometimes they do not respond because the venous return of the blood is very, very poor. So the drug cannot be, diffused. You can try as well the subcutaneous furosemide injections in lower dosages, and they work very, very well. There are other diuretics as well that we also use in heart failure patients, furosemide, for example. Prevention of thromboembolic disease, protein-losing enteropathies are thromboembolic states. These patients have a high risk of developing pulmonary thromboembolism, not only pulmonary, but it's the most common site. With thromboelastography, we can determine which patients have the tendency to become thromboembolic and administer ultra-low dose aspirin. And unfortunately, this hypercoagulability remains even after the treatment. Even if you give steroids, even if you increase the albumin's counts, these patients will remain in a hypercoagulable state. And we can also use clopidogrel, rivaroxaban, and apixaban. Up to now, I didn't have a patient that or I had, 2 or 3 cases in my life that we were forced to use antiplatelet drugs. So it's not my common practice to use them, but we should be aware. Okay, and protein-losing nephropathy, especially in soft-coated wheat enteria that also suffer from protein-losing nephropathy, and there the danger of thromboembolic disease increases. So the treatment of the chronic cases in order to have a maintenance. Okay, for intestinal lymphangiectasia, a commercial low-fat diet, home-cooked low-fat diet, or ultra low-fat diet formulated by a board-certified veterinary nutritionist. And this means that your caloric count should be, your fat, it should be less than 20% of your ME. The fat content should be less than 20%. Okay. Chronic inflammatory enteropathies, you can also use hydrolyzed or hypoallergenic diet, novel protein, a restricted protein source diets, given with a priority to those that are lower in fat, because sometimes you have combined lymphangiectasia and chronic inflammatory enteropathy. There are a lot of commercial diets. Just, compare the fat content and choose the one that has the less content. We have a question. Why in the treatment we don't use albumin if we have ascites about low-level albumin? For me, to do furosemide in this case, it's not a problem of circulation. Why? What do you mean about not use albumins? Of course we do. It's a triplet. We have to restore the albumins, we have to give the diuretics for the ascites, and we have to treat the thromboembolic disease. How do the hypercoagulable present? Pulmonary, yes, with pulmonary thromboembolism most of the times. Most of the times it's with pulmonary thromboembolism. Okay. Please elaborate more on the why we don't give albumins, because we do give albumins. We do infuse albumins in these patients. Okay, we do both. You cannot treat, if you have an over-distended abdomen in an animal that has ascites, a huge ascites dyspnea, you have to treat it somehow in order to debulk, the content, the abdominal effusion. And then when the albumins are higher, when you restore the albumins count, then you can, of course, get rid of wean off the diuretics. It's not going to be for life, but it's like in cardiac disease patients. Okay. They mostly present with pulmonary thromboembolism. But you can have thromboembolism in the renal arteries as well, practically everywhere. But most of them have pulmonary thromboembolism, and you don't have any, in your x-rays, you do not have any findings in dogs with pulmonary thromboembolism. But you always have to keep it in mind if you have a dyspnoic patient that has protein-losing enteropathy and low albumin counts, because once they restore that, the hypercoagulable state, as we said, remains, but it's less. They're less prone to manifest something like that. So diarrhea should resolve within 2 weeks after you initiate the dietary trial. If one diet is not suitable for your patient, then don't be discouraged and start the steroids. Try another dietary trial for 2 weeks as well. Okay, stay either to canned or to dry food. Don't mix them because they have different content in fats and in ingredients as well. Thank you too, Anna. Okay, and let's go now to the steroid, the prednisolone and the prednisone. In intestinal lymphangiectasia, we tend to use lower dose if we ever use them, okay? And if most of the times it is because the lymphangiectasia is secondary to IBD, okay? In primary lymphangiectasia, we rarely use steroids, but if we have to use them, then it's in lower dosages than in chronic inflammatory enteropathies, okay? And this is the protocol. Please be cautious in large breeds because they cannot tolerate high dosages of prednisone. There is, yes, it's human recombinant. It's in my slide. There is how do we infuse albumins in 4 to 6 hours. It's like a transfusion. It's called albumins transfusion. There is a specific IV product that we use, and I have it on my slide. I will, Marina, I will definitely send you the details. Just text me either in social media or an email, and I will send you all the details and the protocol as well. So no evidence that immunosuppressive therapy is useful in treating intestinal lymphangiectasia. Keep that in your mind. Keep that in your mind. Every time that you have an intestinal lymphangiectasia patient, don't start off with steroids. Okay, start with diet. And with the other measurements that I'm going to talk to you later on to restore, the balance, supportive measures. Don't start off on steroids or immunosuppressives, even worse. In dogs with intestinal lymphangiectasia, avoid immunosuppressive dosages, okay, due to the side effects and due to the fact that they cause hyperlipidemia, and we use low-fat diets, and we cause hyperlipidemia when we use steroids, okay, and thrombosis as well. In chronic inflammatory enteropathies, it's different. We use it in higher dosages, and we taper the dosage every 3 to 4 weeks by 25%. It's only obvious that I don't like steroids, and that I'm very, very fond of diets, because I've resolved, and as I have shown you the pie, most of the cases are food responsive, even protein-losing enteropathy cases are food responsive. Okay, and since you start on steroids, periodically check the fructosamine levels in order not to make your dog or cat diabetic. Okay, another steroid, budesonide. Budesonide was, very, very helpful in humans because 80 to 90% has a first pass hepatic metabolism. So only 10% of the medication is in the systemic circulation. So it had less systemic effects. And it acts topically in the mucosa. In dogs, unfortunately, it has been proven that it influences the hypothalamic pituitary adrenal axis, but however, it has less systemic side effects than prednisone and prednisone. So it's a very good candidate. We use it in animals that have pancreatitis, for example, in animals that have iatrogenic hyperadrenocorticism, or in animals that have Cushing's disease, hyperadrenocorticism, diabetes. The dosages are these in the chart. You have a clinical response 7 to 10 days. In children with Crohn's disease, it's a very, very good option, and they do it as an enema in Crohn's crisis, in order to manage a Crohn's crisis. It can be used as an enema. The same is in dogs, can be used as an enema as well when we have a flare-up. But it's very, expensive. So if owners can afford it, then it's a very good choice. And let's go to cyclosporine. I like cyclosporine. A lot of cases are handled as a monotherapy. It could be an add-on therapy to prednisolone or steroids, but I tend to use it as a monotherapy. You should have therapeutic levels and monitoring 60 hours post initiation. Always sample. When there is this thing about medication that we never know when to sample, okay, and we get different results. So for cyclosporine, use it, sample at nadir, 12 hours post-pill, always. Please be very cautious. If you have a stray dog or a stray cat that you maybe treat with cyclosporine, they're very, very prone and endangered to catch toxoplasmosis and leukemia virus and FIV infections. And priorly to initiating this medication, cyclosporin, you should always screen for toxoplasmosis because they could die, FeLV or FIV infections, okay? Reduce the dosage by 50% if you have vomiting or anorexia. And of course, there are a lot of interactions with other medications, like you can use ketoconazole for reduction of dosage of cyclosporin. Other immunosuppressives that I rarely have used. Up to now, most of my IBD cases and the majority of my PLE cases could be handled very well with dietary modifications and with supportive treatment, and with some of them with steroids. Yeah, I will admit that. So if you have to use an immunosuppressive, I would go for chlorambucil for dogs and cats, both dogs and cats, okay? Azathioprine, only for dogs, not for cats, okay? But you should always check for and monitor due to myelosuppression, okay? Mycophenolate, I have treated some patients with mycophenolate, but it carries a risk of GI. What are the prerequisites before performing endoscopy and any special anesthesia protocol? Okay, we will talk about that. Mycophenolate carries the risk of significant GI adverse effects. It's not a good choice to treat inflammatory protein-losing enteropathies and generally inflammatory chronic enteropathies. But some refractory cases, yes, I have used mycophenolate. I don't want to hear anything about cyclophosphamide or methotrexate. Yes, they do exist protocols, but you know, you have always to measure the pros and cons. My suggestion, and I heard that from Stan Marks last week, and I said that this is an amazing pearl that we should always keep in mind, is that if you want to use immunosuppressive, don't use 3 agents at the same time. So let's say that you choose, for example, prednisolone, and you add on chlorambucil or azathioprine. Don't add on a third on. Stick to 2 immunosuppressives, okay? Don't add a third one on the regime. This, if you are up to the point that your animal does not respond to 2 medication, to 2 immunosuppressants, then this means that you either lost the diagnosis somewhere or that this is a refractory case. We've talked about in the first slide that 50% of your cases will not respond to immunosuppression or steroids, okay? So you have to do other things, and I will tell you what other things are safer to do. And a lot of cases respond to octreotide, okay? Can be a beneficial rescue treatment if you have a refractory case. So this is one of your solutions, for example, octreotide. And let's go to our other. I love cobalamin supplementation, as I told you. So in most of my IBD or PLE cases, what I do is dietary modification, cobalamin supplementation, and folate if needed. Okay. Calcium, if I have ionized calcium deficit. Okay. Magnesium, if I have hypomagnesemia. Calcitriol, if we had the low 25-hydroxy vitamin D. Probiotics, this is a huge, add-on to our treatment. And there are probiotics like Vivomix or like Fortiflora that do amazing things that are very, very rich in populations that are very, very effective to dogs and cats, like Vivomix, as I told you, Vivomix and Fortiflora. What we tend to, of course, with probiotics, the thing is that they act only for the time that you're giving them, as long as you give them. And the second thing is that we tend to have a more, I don't know if you have heard of the term precision medicine, which means that it's tailor-made medicine. And we should have for each disease a certain probiotic because different populations are affected. bacterial taxa are affected. Metronidazole and xylazine, I will not say anything. You know, we've said so far a lot of things, but if you want to use it, xylazine, you can use it even once a day, not 3 times a day. Okay, and metronidazole in cats, please, because I had a discussion with one of our colleagues today, use it in cats in very low dosages, like 7.5 milligrams per kilo twice per day. This is another huge sector that I wanted to discuss with you, how to do fecal transplantation, microbiome transplantation. This is the future. We've done it in a lot of refractory cases. So in cases that you have given everything, this is a very good solution. So the animal has to be at least 12 months old to middle age in order to be a donor, okay? Clinically healthy. There is a specific protocol for checking all the infectious diseases. The donor should not be on raw food for a lot of days. And in general, we shouldn't be on raw diets, neither us nor animals, okay? Medication, in terms of supplements and medication, the donor should not have taken medication, antibiotic, at least the last 6 months. And we say that, by saying that, you understand how much of a problem the antibiotic usage creates to the microbiota. And what else? I have made some notes in order not to forget what to tell you. We do an infectious disease screening in the donors, okay, that include Giardia, Cryptosporidium, Campylobacter, other intestinal parasites, Trichomonas fetus PCR, also additional screening, you know, for Clostridium perfringens toxin gene. That's not, you know, that's optional. And the dosages and applications, first of all, it's very safe. I've done it a lot in a lot of parvo puppies, and they got, thank you, Anna. And we had very few adverse effects, even in immunocompromised dogs, because I know that that's your concern. How will I insert, you know, microflora in an animal that's immunocompromised or that has very low neutrophilic count, like the parvovirus, for example, patients. So it's very safe. It's very safe. You can do it through capsules. You can do it through an enema. The enema retention times, it's around 30 to 45 minutes. So you probably have to sedate your animal. Okay, it could be in animals that are very patient. You can do it without sedation, but I would, you know, definitely do it in a sedated animal with Foley catheters. Parvovirus enteritis, acute colitis, chronic enteropathies, these are the indications. Okay, these were all the things that I have actually written down to tell you about fecal transplantation. And this is why I have been so persistent with the Clostridium curinonis populations. You, after this lecture, you will have to be in love with Clostridium curinonis, okay, and with the dysbiosis index. So we have patients that we have given different 4 or 5 different diets. We have tried steroids, all the steroids. We have tried cyclosporine. We have tried every immunosuppressant disposable available in the market, and they still have watery diarrhea. Why is that? And as we said that, this is because we have excessive primary bile acids. Up to 40% of people with Crohn's disease have bile acids diarrhea. Unfortunately, it's underdiagnosed because we don't have biomarkers for that, and it's untreated. Up to 32% of people with irritable bowel syndrome have bile acids diarrhea. Dogs, we tend to detect in dogs as well bile acids diarrhea, and we use cholestyramine. This is the solution in these dogs. If you have done everything, if you've given supportive care with, cobalamin, folate, with every probiotics and prebiotics or symbiotics, okay, and you have no other solutions to use in your patients, then you could as well use cholestyramine. And I know, don't do it as a first line, because I know that a lot of you will, jump on giving cholestyramine to every patient. The indications, possible indications, because it's still, very, very novel, is the dogs that have non-responsive diarrhea and they have persistently decreased population of Crystridium curinonis or increased populations of primary bile acids. These are dogs that have not responded, not even to fecal transplantation, because we have patients like that. And I see all the time working in a referral practice, okay? Or you have a quick relapse after the of diarrhea after the fecal transplantation. And the fecal transplantation is not just once, you repeat it as well. Maybe you have refractory cases to high dosages of corticosteroids or non-response to second-line immunosuppressive, as I said, and after ileal resection. So this is another solution. So what do we do to sum up? Because I know it took more than 1 hour, but thank you so much for staying over. We have to exclude parasitic diseases. We have to exclude food allergies, okay, and then food intolerance with dietary trials. Exclusion of ARD, this is a bit questionable whether to use or not antibiotics as a first line, as we said. We used to say that, but now everything has changed during the last year, during 2022 and 2023, with new research out there. And if you haven't reached up to a conclusion, then you definitely need advanced diagnostics. And with advanced diagnostics, we will reach out to steroid immunosuppressive responsive diarrhea, to enteropathogenic bacterial disease like the attaching and invaded Escherichia coli, for example, the histiocytic colitis, irritable bowel syndrome, and the steroid immunosuppressive responsive diarrhea includes also alimentary lymphoma, and maybe lymphangioplasia, okay? And my last slide, for the cases that you have lymphangioplasia with concurrent PLE, and Patrick, this actually answers your question. Severe dietary fat restriction, less than 25% of fat on a caloric basis. This is ultra low fat, okay? And I want you to keep the second sentence. Response rates with the dietary management of non-infectious, non-neoplastic protein-losing enteropathies are very high. Only with diet, 73 to 85% of cases, and this is published data, okay, can respond. I know that steroids and antibiotics are very easy to prescribe, and you give your, rather than fighting with the owners over different diet trials, but it's worth it. It's really worth it, okay? Tilapia also, which is a fish, and I will definitely give you all the metronidazole dosages. Let me finish that, and then we will get into all the questions. Tilapia is a fish, and we use the skin for patients in human medicine. They use the skin for patients that have extended burns in their body. So the skin is used for extended burns. Maybe I'm not, aware if it has ever been used in canine or feline patients with extensive burns. Okay, tilapia and rice, or low-fat chicken, rice, cottage cheese, sweet potato, but it has to be under a nutritionist guidance, okay? Also, critically ill dogs, when we have to tube feed them, could be on a full elemental diet like Vivonex or semi-elemental diet or a polymeric formula, okay? And the enteral route of feeding can be ensured by a feeding tube. No clear evidence for immune-mediated etiology of PLI, as I told you. So immunosuppressive treatment should be very carefully considered. Dogs with protein-losing enteropathy that only show marked inflammatory infiltrate on intestinal biopsies, and they lack an adequate clinical response to diet. These are the ones that we should try anti-inflammatory or immunosuppressive treatment. An absence of infectious etiology, antimicrobial treatment plays no role at all in canine PLE. I hope that I persuaded you. Okay, let's go to the questions. What are the prerequisites before performing endoscopy? This is an anesthesiology question, but what we normally do at the clinic is that we fast animals for at least 12 hours, okay? And the anesthesia protocol, we either use diazepam and propofol and isoflurane and maintenance with isoflurane, or if there's any other specific, if I have an animal with dyspnea, for example, due to an ascites or due to the compression of the diaphragmatic wall, then I consult with the anesthesiologist. But most of the times I use, for example, diazepam, propofol, induction with propofol, and maintenance with isoflurane or sevoflurane. Okay. Let's see, Andrea. The dosage of metronidazole, it's lower because they cannot metabolize it correctly due to its neurotoxicity. Okay, Andrea. And the dosage of metronidazole in dogs has variations. For example, in Giardia, we go up to 40 to 50 milligrams per kilo twice a day. In liver diseases, we can go up to 15 milligram per kilos, and in pancreatic diseases. And in intestinal diseases, we can go up to 15 milligrams per kilo, 15, 20 milligrams per kilo. Okay. So it depends on the disease also. It's disease-oriented. It is disease-specific, the dosage of metronidazole. And in cats, it's always lower, 7.5 actually. What do you say, Patrick? What do I say about food to our clients when they come for a first visit for acute diarrhea? For acute diarrhea, I tend to use... for aqueous diarrhea. Okay, for aqueous, you mean watery diarrhea, correct? So for watery diarrhea cases, what we do is that first you have to make a location, Patrick, to see if you have mixed diarrhea, if it's both from small intestine and from large intestine. So your approach will be different. But I tend to use, if I have small intestinal diarrhea, I go with either a novel protein diet, okay, or with a low-fat diet. And I stick to either canned or dry food. And also, Patrick, it depends on whether the animal has vomitings as well. So if you have an animal that's vomiting as well, I would, go with a low-fat diet. If I have an animal that has also symptoms of pruritus and it's itching, then I would go with a novel protein. So it depends on your clinical history. This is why your whole therapeutic regime and approach on diet will be defined by the symptoms and by your clinical history. What about heparin? We do not use heparin in the thromboembolic disease of protein-losing enteropathies. As I told you, we use ultra-low dose aspirin or clopidogrel most of the times in these patients. In other patients, you might use heparin, but in these patients, for example, I know that you have in your mind the thromboembolic disease of of hypertrophic cardiomyopathy in cats. It's totally different, okay? Is it right to do gastroscopy and colonoscopy at the same time? Absolutely. If you have a mixed bowel diarrhea, if you have symptoms from both the large intestine and small intestine, definitely, Dr. Gudaman, you can do both. But which one will you do first is the thing. You will never do your colonoscopy first, okay? Because if you have only one scope, you will not put your gastroscope in the colon and the large intestine and then use it in the small intestine, okay? And in the stomach, in the esophagus. Of course you can do it, but you have to prepare your patient very well. And if you have an hypoalbuminemic patient, I don't know if you're talking in general or if you're talking about the protein-losing enteropathy cases, because if you have a highly hypoalbuminemic patient and you want to do both, it's very, very difficult to do the 3 days protocol to clean the intestine, the large intestine, because these patients are severely diseased. So I wouldn't advise in a hypoalbuminemic patient to do both procedures, okay? Because you will deprive the patient of 3 days of proper feeding. And these patients need the caloric content. Thank you all for attending. Okay, and one last one. If we need to change the food, do you recommend to do it at one or to do it in a transition? Or in time for 2 weeks, like they recommend when we want to try new food? Okay, no, you will wait for at least 2 weeks in order to see the response that you're having. You don't have to wait up to 6 to 8 weeks that we were, we were saying a few years back. You will have a response, a clinical response in the first 2 or 3 weeks. And then, you can do, you can either do a transition over to 3 to 4 days. Anyway, you do the transition because this dog or cat has not responded. Okay, so this means that it still has clinical symptoms. So you can have transition of 3 to 5 days and then go to the next clinical diet. Thank you so much, everyone, for attending. It will be in the my favorite protocol, Jacqueline. It will need time. I will send it in an email. Okay, it's with Clean Prep. It's a powder that we use also in humans. But if you want a specific protocol, I will send it to you with an email. We use Clean Prep. I use low-fat canned diet, 2 spoons with warm water. Some people do it in human medicine. They do it also with milk, but I don't like that. And with Clean Prep. But I will send you the protocol. Send me an email. Thank you very much, everyone. And I will see you next month. I know that it took more, but this was a very, very important session. In order to give all the new updates that we have in gastroenterology and in endoscopy. And we're going to go next month, end of September, with another hot topic as well.
Thank you, Dr. Vasilikki. It's a very wonderful webinar. So many questions. Seems like they all are enjoy this webinar. See you next time.
Thank you very much. And Jacqueline, you'll have to email Aohua, and Aohua will send me your requests. Okay.
Yeah, please contact us via this QR code. Please,
yes,
maybe
go to these codes. This is why we have them here.
Yeah, please.
Thank you very much. Back to first day at school, to schools, and back to work. For those of you who are not having any more vacation, and please feel free also to share your cases if you want. For us to discuss any cases, that would be amazing. Thank you, Jean-François. Thank you. And I will do some in French as well, because I think that we have a lot of French-speaking people here. Alors, à la prochaine. À tous. À tous et à toutes. Thank you.
Okay, so see you next time.
Jason, they asked about PDFs. There's not going to be any PDFs, but Aohua uploads everything in Aohua Vet YouTube channel. Go to the YouTube channel, okay, and you will see all the webinars uploaded and also the clinical cases. So you will not receive a PDF, but you will have all the recorded material of every webinar, if you want, for free to revisit.
Yeah. As you are attendees, you will receive our webinars record in 1 month when it is ready. So don't worry.
And if you go now to the YouTube, you will see all the previous or some of the previous webinars that have been uploaded.
Yeah, and some of the cases in the webinar will upload on the YouTube.
Yes, definitely. Thank you.
Okay.
Goodbye, everyone. Till next time.
Goodbye. See you next time.
See you. Bye, Jason.
Bye.